Good morning, everyone. Welcome to Grand Rounds. Before I introduce Dr. Tedford, few housekeeping items. We are broadcasting live via live stream and YouTube. Please use microphones to ask questions, and recording is always available for viewing on YouTube. And consider subscribing to our YouTube channel to get notifications when videos get added. For our viewers, if you would like to submit a question, text DeBakey to 37607. You can also submit questions via live stream feed. And you can find the video on livestream.com/HMH-edu. Also wanted to plug in for a couple of conferences. Tomorrow is our George P. Noon conference. The whole day it's on chronic management of LVADs. So we have, 6 wonderful outside speakers, a lot of our own faculty speaking. So please make every effort to attend. There's also a transcranial Doppler imaging and vascular ultrasound masterclass on December 2nd for people who are interested. So it gives me really a great pleasure to have Dr. Ryan Tedford come here. Dr. Tedford is a professor of medicine, and Dr. Peter C. Gaze is chair in heart failure. He's the chief of heart failure at MUSC. But more importantly, he's a trailblazer in the field of invasive hemodynamics and really defining RV failure in the context of pulmonary hypertension, scleroderma. Some of the seminal papers he's written on, how to define group 2 PH, and his work on using invasive hemodynamics to define all of this. They have really changed the field. So much so he's going to be the co-chair of Group 2 PH in the World Symposium for Pulmonary Hypertension, which is a great honor in itself. He's published, multiple papers, over 200 papers, multiple invited reviews and commentaries on hemodynamics, RV failure. It's really an honor to have you here and to come and talk to us and teach us about use of invasive hemodynamics. Thank you.
Ash, thank you so much. It's always an honor to be invited by friends to talk about my favorite ventricle, the right ventricle, or as you all tweeted yesterday, forgot no more ventricle. So I do have some disclosures, hopefully none of which are particularly relevant for the talk, but one of the things that Ash did not tell you is that I actually am a Texan. I went to the University of Texas, so I bleed orange, but I also grew up in Dallas, and so I'm a Cowboys fan. And so I thought it would be a good idea to share with you some statistics when it comes to Cowboys versus Texans. I did a little research and I found out the last time the Cowboys and the Texans played was in 2022, and the Cowboys were victorious. The largest margin of victory, 34 points, again by the Dallas Cowboys. All-time wins, Cowboys 4, Texans 2. And then Super Bowl victories, we won't go there. And then finally, because I'm from Dallas, I'm also a Rangers fan. So I'm going to finally realize a World Series championship. So let me go over with you a few objectives that I'd like to meet over the next 45 minutes. The first is to describe a clinical observation, and I think very importantly for the fellows, residents, and trainees in the audience, ultimately an incorrect theory that we had that led us to investigate right ventricular loading conditions and contractility in a condition called systemic sclerosis. We'll then appraise emerging data on the role of right ventricular reserve, including potential diagnostic and prognostic implications. And in the last few minutes, we'll illustrate how these techniques may better help us predict and mitigate the risk of right ventricular failure after left ventricular assist devices. So I think you all are familiar with systemic sclerosis or scleroderma. It is a multi-organ autoimmune disease. It's characterized by fibrosis, immune abnormalities, and microangiopathy. You'll notice the characteristic small oral aperture, the telangiectasias that occur, the skin tightening of the hands, the sclerodactyly. These individuals have esophageal dysfunction, interstitial lung disease, and angiopathy that impacts multiple organs, including the fingers causing Raynaud's phenomenon and the kidneys causing sclerodermal renal crisis. And then, of course, pulmonary hypertension, and in some cases, right ventricular failure. So it turns out that if you look at the course of systemic sclerosis, the leading cause of death has really dramatically changed over the last few decades. If you go back to the 70s, it was scleroderma renal crisis that contributed to the majority of mortalities in these patients with systemic sclerosis. But with the advent of ACE inhibitors and the realization that this could treat and terminate in acute crises, what has replaced scleroderma renal crisis as the leading cause of mortality are lung complications, principally among them pulmonary arterial hypertension. So Micah Fish and Paul Hirsoon were really some of the first to suggest that patients with systemic sclerosis, once they develop pulmonary hypertension, have worse outcomes than other forms of pulmonary hypertension, in particular idiopathic pulmonary hypertension. In this early study, the median survival after diagnosis was only about 3 years. Thankfully, this has improved a little bit over the next couple decades, but it's still not as strong or not as good as to other forms of pulmonary hypertension. The same investigators made some very interesting hemodynamic observations when they compared these two groups. They first noticed that the patients with systemic sclerosis actually had lower pulmonary pressures, lower pulmonary vascular resistance than the idiopathic PAH counterparts, yet they had similar degrees of depressed cardiac function despite that lower right ventricular afterload. And so there's really two possible hypotheses for these observations. First of all, these individuals might have a heart problem. That is, perhaps they have intrinsic right ventricular dysfunction, myocyte injury from fibrosis, inflammation, or small vessel ischemia. Or they actually have a lung problem, or more specifically, a lung vessel problem. And perhaps pulmonary vascular resistance, the most common way we estimate afterload in the cath lab, may not accurately reflect the total afterload imposed on the right ventricle. And perhaps there's an increase of what we're going to call pulsatile loading due to stiffening of the proximal pulmonary arteries. Now, being a cardiologist, I blame the lung whenever possible. And so indeed, this was our initial theory, that these individuals had stiffening of the proximal vessels, and this was contributing to unmeasured afterload, perhaps accounting for more right ventricular dysfunction. And so before we really get into that, I want to take a step back and talk a little bit about afterload, first in the systemic circulation. Now, I'll remind you that the two principal determinants of afterload are compliance, how stiff the vessel is, the blood storage capacity of the system, and resistance. Now, in the systemic circulation, most of the compliance, most of that blood storage capacity is located in the proximal aorta, about 80% of the total compliance, whereas the small vessels account for only about 20% of the total compliance. Resistance, on the other hand, is all accounted for in those small distal arteries and arterioles, because we know resistance is inversely proportional to the size of the vessel. Now, blood, of course, is not steady state, it's pulsatile, and these pulsations travel down the aorta, they reach reflection points in the periphery, and this results in wave reflections. Now, hopefully all of us in the room here are young and healthy. Actually, these are of very little consequence. But as we get older, we get stiffening of the proximal aorta. This results in lower large vessel compliance. We now have an increase in pulse wave velocity and intensity, and this results in enhanced wave reflections that then return during ventricular systole to elevate afterload. And this is in part why we see isolated systolic hypertension in the elderly, and we have this augmentation pressure, aortic pressure augmentation at the end of systole in aortic pressure tracing. Now, an important thing to remember here is the difference in geographic distribution between compliance and resistance in the systemic circulation. Compliance is proximal, resistance is distal, and it turns out that that's very different in the pulmonary circulation. So our question, again, based on our hypothesis, is do disease states like pulmonary arterial hypertension, advanced age, or connective tissue disease-related pulmonary hypertension lead to stiffening of the proximal vessels and a higher unmeasured pulsatile afterload? And indeed, this was the paradigm just over a decade ago, that proximal pulmonary vascular wall stiffness was a major contributor to right ventricular afterload and pulmonary hypertension. So back in the mid-2000s, there was some really intriguing work that came out of Anton van Noordegraf's lab in the Netherlands. This was their first study, very small, only 30 patients. that included patients without pulmonary hypertension, which are the black dots, idiopathic pulmonary hypertension, which is the white triangles, and then patients with chronic thromboembolic disease pulmonary hypertension, many of which have proximal clot burden in the pulmonary vasculature. And what you can see here is that they noticed a very unique relationship between resistance and compliance. So as your resistance increased, compliance fell in a predictable manner. This relationship between resistance and compliance was conserved such that the product of the resistance compliance, the RC time, or the diastolic decay constant in the pulmonary artery, actually was unchanged in health and disease. They went on to study this relationship before and after treatment of pulmonary hypertension. And here you can see as they gave those individuals pulmonary vasodilators, resistance fell, but compliance increased in a predictable manner along this inverse hyperbolic curve. There was no difference in the RC time before and after treatment. So we found this very interesting because it was very different than what we know in the systemic circulation. So we looked at over 1,000 patients with either known or suspected pulmonary hypertension, all of which had normal left atrial pressure, and we found this same inverse hyperbolic predictable relationship between resistance and compliance in the lung. You can see this is very different from the systemic circulation, which is now shown here. And this is really best highlighted when we plot the RC times of the two circulations versus either the mean pulmonary artery pressure or the mean systemic pressure. The open dots here is the pulmonary vasculature, and you can see that RC time is really highly constrained, around 0.5 seconds, where in the systemic circulation it's much more varied. And again, why is that? It's because we can change compliance without altering resistance in the systemic circulation, where they're very, very tightly connected and dependent on one another in the pulmonary circulation. So we then wondered, well, does aging impact this relationship? And so we took those 1,000 patients, we divided them into age tertiles, with the black representing the youngest patients, the green the intermediate, and the red the oldest. And when you look at this pulmonary RC curve, you can actually see those dots are pretty evenly distributed across that curve, perhaps a slight downward shift with the red dots, but nowhere near what we see in the systemic circulation, where those older individuals dominate the lower compliance portion of the curve. Well, how about then in systemic sclerosis? Is there a change in compliance independent of resistance in this group because of stiffening of the proximal vessel? We compared 67 patients with idiopathic pulmonary hypertension to 166 with systemic sclerosis, and we really saw no difference whatsoever. Also here when we look at the RC time. So this seemed to be counter to our theory. So ultimately we felt like our initial hypothesis was incorrect, but we learned something along the way. And that is that in the pulmonary circulation, the large vessels account for only about 20% of the total compliance of the system. And why is that? And that's because compliance is more evenly distributed across the pulmonary bed, and it's the small distal vessels that are responsible for the lion's share of compliance, the same ones that are responsible for resistance. And that's why these two determinants of afterload are so intimately related. Why does this occur? Well, if you think about it, there's about 8 to 10 times more small distal arteries and arterioles in the pulmonary circulation compared to the systemic circulation. So there's a lot more blood storage capacity out at the periphery compared to the systemic circulation. Now you might say, well, Ryan, that's great. That's kind of a cool theoretical hemodynamic argument, but does this really translate into a clinically meaningful, relevant point? And so this is a really nice animal study done by Kuo and colleagues at the University of Michigan, where they built a circuit that had a compliance chamber and a variable resistance clamp, and they connected this circuit to the pulmonary artery of a sheep. And so then they could alter compliance and resistance and look at the impact on right ventricular function. Now importantly, the natural compliance of the lungs were still maintained because they reconnected to the distal portion of the proximal pulmonary artery. So the first thing they did is they increased resistance. So they turned that variable resistant clamp to increase PVR from 2 to 4 to 6 to 8. And you can see as resistance increased, cardiac output fell in a very predictable manner. But then when they changed the compliance of the system, when they made that proximal compliance chamber very, very stiff, you can see the change in cardiac output was actually very negligible. again suggesting that that proximal vessel doesn't contribute very much to total right ventricular afterload. So back to our hypotheses, again, it seems that in fact these individuals must have a heart problem, but that had really never been shown by our traditional measures of right ventricular function like echo and MRI. And so the next question then is, how do we best assess right ventricular function? And so, of course, the right ventricle is a little bit difficult to assess. The same determinants of function that impact the LV impact the RV, right? Preload, afterload, contractility, and lusitropy, or active relaxation. But we know that the RV is much more sensitive to perturbations in afterload. So this is a slide that's shown at every RV talk, right? We all know this very well. We know that in this example, a dog model, an increase of mean pulmonary artery pressure, just 15 millimeters of mercury, results in a 30% decline in RV stroke volume, whereas if we increase systemic pressure, systemic mean pressure by 40 millimeters of mercury, only about 10% decline in LV stroke volume. And so this is, of course, why patients who have an acute PE don't tolerate it. It's why Cindy and Arvind cannot transplant a patient with fixed pulmonary hypertension with a nice, fresh, young heart, because the RV will fail, right? But I think what's less appreciated is that the RV remains afterload sensitive even in the chronic setting. So this is one of my favorite, very simple hemodynamic experiments done by Anna Himnes and John Newman at Vanderbilt. They measured hemodynamics before and after administration of inhaled nitric oxide in patients with vasoreactive pulmonary arterial hypertension. So by definition, these individuals had a significant decline in pulmonary pressures and pulmonary vascular resistance, and then this was met by a significant increase in RV stroke volume. So this really reminds us that RV function in particular is determined by coupling of RV contractility, the intrinsic ability of the RV myocytes to stiffen, and the afterload imposed on it from the pulmonary circulation. It also means that a lot of our clinically used measures to assess RV function, like stroke volume, RV ejection fraction, fractional area change, and TAPSE, are load dependent, and they may not give us a good sense of the intrinsic function of the right ventricle. So how do we best assess right ventricular functions? If you've heard me give a talk before, I always have to talk about pressure volume loops. So with apologies, I'm going to go through this and take you back to medical school a little bit. This, of course, represents a single cardiac cycle. We're going to begin here at the end of diastole. This is our preload, or RV end diastolic volume. The tricuspid valve has closed, initiating the onset of systole. Now, the first thing that we have here is our isovolumic contraction. We have an increase in pressure without any change in volume, at which point the pulmonic valve opens. We begin ejecting blood into the pulmonary circulation. We have a decline in our RV volume, at which point our pulmonic valve closes, initiating the onset of diastole. We have our isovolumic relaxation, a fall in pressure without any change in volume, and then our tricuspid valve opens and we fill the right ventricle again. And the width of that pressure volume loop is, of course, our stroke volume. Now, it turns out that we can measure contractility, probably in one of its most purest forms, based on the principle that the ventricle is an elastic structure that will stiffen and relax along a predictable time course in the cardiac cycle. And so if we can create a family of pressure volume loops, most commonly done through preload reduction, we can determine the end systolic pressure for each one of those loops. This is the point of maximal pressure and volume for each loop. And the slope of that relationship is the end systolic elastance. This is a relatively load-independent measure of contractility. Now, we can also estimate afterload on the pressure volume loop, and it turns out that if we could sum up the RV systolic pressure throughout ejection, this would be a good estimate of afterload. And it's been shown that you can estimate this by taking the end systolic pressure, dividing by the stroke volume, and this gives us something called the pulmonary effective arterial elastance. This is a lumped parameter that accounts for both resistive, like PVR, as well as pulsatile load, and it's a better marker of total afterload than each individual components. We can then look at the ratio of those two elastances, which is a unitless measure to determine coupling between the RV and pulmonary circulation. Okay, but is the RV, is it feasible to perform a pressure volume loop, right? The RV is highly trabeculated, it's crescent shaped, it's difficult to manipulate. To my knowledge, the first RV pressure volume loop was done in the basement of Johns Hopkins by Lohmann and Mike Weisfeld back in the 70s. This was in a dog. And you'll notice that the pressure volume loop is a little bit different than what you might remember in medical school. It's actually triangular shaped. And that's because in a normotensive dog, and in all of you, the RV is ejecting into a very low impedance circuit. And so pressure is actually falling throughout ejection, which accounts for that fall in pressure that you see here. But they showed it was feasible, and that also that end-systolic pressure-volume relationship, or end-systolic elastance, was sensitive to both inotropic stimulation as well as beta blockade. So this is, in fact, feasible. And so we said, well, maybe this would be a good way to better understand the RVs of our patients with systemic sclerosis. So to our knowledge, this is the first PV loop done in a human with pulmonary arterial hypertension. We altered preload actually through either a combination of a Valsalva maneuver or just external IVC occlusion, as opposed to the old traditional IVC balloon occlusion. But we see a very nice end-systolic pressure-volume relationship here. And indeed, this was our first study, and we saw significant differences in contractility between systemic sclerosis and idiopathic pulmonary hypertension. This is a larger study that just summarizes those results. And at first I want to point out here that the RV ejection fraction by MRI was actually no different in this group, yet significantly lower contractility in the patients with scleroderma, and the coupling ratio was impaired in the patients with systemic sclerosis compared to a normal ratio in the patients with idiopathic pulmonary hypertension. We then wondered, well, what is the mechanism behind this RV dysfunction, and could we reproduce this at the single myocyte level? And so after consent, we actually performed RV biopsies on these individuals, echo-guided biopsies. I gave those biopsies to a colleague, Stephen Su, who isolated single myocytes, skinned them so we only had the contractile apparatus, which is shown here, and put them on a forced transducer. We then exposed those myocytes to different levels of calcium concentrations to create these forced tension curves, which you all have seen before. There's three different curves here. We have the blue curve, which is idiopathics. We have the black curve here, which is normals, which we obtained from Ken Margulies at Penn. And then we have scleroderma patients shown down here. You'll first notice that the idiopathic patients, the myocytes appear to actually be supercontractile. This has actually been shown before. But the patients with scleroderma have a true contractile impairment, even at the myocyte level. Importantly, the cross-sectional area of these myocytes were no different. So this was not an issue of just picking the most hypertrophied or least hypertrophied myocytes. So let me summarize what I've told you. If you have a normal RV and you develop pulmonary hypertension, you increase afterload, but that RV has reserve. The contractility can increase to match that afterload. The ratio of elastances is preserved, and RV-PA coupling is preserved. On the other hand, if you have a diseased RV, in our case, patients with scleroderma, perhaps heart failure with reduced or preserved ejection fraction, and certainly an RV after left ventricular assist device, if you develop an increase in afterload, the contractilities are already maximized. It cannot increase to match that afterload. The ratio of elastance declines, and the RV-PA unit becomes uncoupled. Now, invariably, when I've given part of this talk in the past, somebody in the back says, well, that's great, but does this really matter clinically? Does multi-beat pressure volume loops actually predict outcome? And we have a couple of studies now to suggest that it does. This first study is done by Manuel Richter and Koder Tello from Gießen, Germany, 38 patients with pulmonary arterial hypertension. The cut point here for the coupling ratio was 0.7, and you can see that coupling ratio discriminated those patients with pulmonary arterial hypertension who went on to have clinical worsening at follow-up. We looked at our data and saw a very similar cut point, around 0.65, that discriminated event-free survival in patients with pulmonary arterial hypertension. And again, I want to point out here that these individuals had a preserved RV ejection fraction on average by MRI, suggesting some of these patients have hidden right ventricular failure. When we looked at just other parameters to predict time to clinical worsening, all of these metrics of structure and function by MRI, none of them were statistically significant. We've also used these techniques to try to understand the disparate outcomes between men and women in pulmonary arterial hypertension. We know women try to do better, And in this study, in collaboration with Tim Lamb, we found that women have a better contractility than men in all comers, as well as just specifically in idiopathic pulmonary hypertension, and their coupling ratios are more preserved compared to men as well, again, perhaps accounting for some of these differences. So let me summarize again what I've told you so far. The proximal vessels account for very little of the overall compliance of the pulmonary circulation and afterload. Systemic sclerosis-related pulmonary hypertension patients have intrinsic RV dysfunction, both globally and at the myocyte level, and an inability to compensate for increases in load. And finally, while pressure volume assessment is the gold standard and predicts prognosis in pulmonary hypertension, it's probably not feasible for clinical practice. And in fact, you probably have heard this quote before. Stephen Hawking says, time travel may be possible, but it's not practical. Maybe you did not know that his other quote was that PV loops may be possible, but in fact, they're not practical. So with that in mind, let's shift a little bit and talk about this idea of RV reserve for diagnosis, prognosis, and perhaps as a surrogate measure for RV-PA coupling. So what is reserve? Reserve or contractile reserve is the capacity of the ventricle, either the right or the left ventricle, to increase contractility at a given afterload, at a given level of loading. And typically that's done with either exercise or a pharmacologic stressor like dobutamine. Is there diagnostic value of RV reserve? I'm going to give you 3 different examples. The first is in heart failure with reduced ejection fraction. My good friend Mark Riguazzi in Milan did this study, about 100 patients with HFrEF who underwent both an echo stress test as well as a cardiopulmonary exercise test. Now, Marco first divided this group based on resting RV function. So group A here, normal resting RV function defined by a TAPSE greater than 16 millimeters. The second group, the red group, had abnormal resting RV function. But then he performed that exercise stress test and looked at the change in TAPSE during exercise. Group B here are those individuals that maintained or improved TAPSE with exercise, where Group C actually had a decrement in TAPSE during exercise. They lacked RV reserve. He then compared the functional capacity of these 3 groups and made some interesting observations. So Group A and Group B are pretty much indistinguishable. Again, Group A, normal resting function. Group B, abnormal but actually had reserve. You can see their peak VO2 was the same. The peak O2 pulse, a surrogate for stroke volume, was the same. Their VE/VCO2 slope and their exercise oscillatory ventilation, really no different. But where he really found the difference is the group that lacked reserve, right? So they had much lower functional capacity, higher VE/VCO2 slope, more exercise oscillatory ventilation. Really significant functional differences between these groups. What about in HFpEF? One of many studies from Barry Borlaug at Mayo. In this study, he looked at 50 patients with HFpEF compared to 24 controls. These individuals had no difference in resting hemodynamics or measures of RV function, but during exercise, you can see those individuals had evidence of RV reserve impairments as measured by changes in RVS prime. And finally, idiopathic pulmonary hypertension out of Europe. 16 patients with pulmonary arterial hypertension and 18 age-matched controls. 2 different measures of RV reserve here, changes in S prime and changes in TAPSE. Now, when you compare controls to PAH, when these individuals were given dobutamine, you might say, well, this is expected, right? The patients with pulmonary arterial hypertension had impaired RV reserve. But when you look within the PAH group, what you'll notice there is the different colored dots, right? So the red dots have depressed function at rest. Probably not surprising they had impaired reserve, but in fact the open dots actually had normal RV function at rest. Again, suggesting that in this group with normal RV function at rest, some individuals have impaired RV reserve and perhaps hidden right ventricular failure. What about the prognostic value of RV reserve? I'm going to give you 2 examples. The first, again, going back to patients with heart failure with reduced ejection fraction, this study out of Japan. Looked at 3 different measures of reserve: fractional area change, TAPSE, and RV free wall longitudinal strain. We're going to focus on the bottom here. The patients who did not have a subsequent heart failure event in follow-up, you can see had evidence of RV reserve, that is, that they had improvements in longitudinal strain with dobutamine, whereas the patients who had a future heart failure event, again, lacked RV reserve. And finally, this work from Greg Lewis and Doreen DeFario at MGH in congenital heart disease. They actually developed an RV risk score based on the peak RV ejection fraction as well as the change in RV ejection fraction during exercise. And you can see those individuals with either mild or moderate RV reserve impairments or severe impairments had worse event-free survival at follow-up. So can we relate this idea of RV reserve to our gold standard assessment of ventricular function, RVPA coupling? This is an animal study by Guerre and colleagues where it was a piglet model of pulmonary hypertension. They performed pressure volume analysis, and then they gave these pigs dobutamine and looked at changes in stroke volume index. You can see that the pigs with the most severe uncoupling had the least increase in stroke volume index, and there was a relatively linear relationship between stroke volume index reserve and our gold standard of RV assessment, RVPA coupling. So we thought this would be an interesting idea to study in our patients with pulmonary hypertension. This is sort of what it looks like when we're in the cath lab. We have an exercise physiologist with a metabolic cart so we can measure a gas exchange and do direct fit cardiac outputs. We have a supine bicycle ergometer here. We have our Inca machine with conductance catheters to perform pressure volume loops, and we have lots of support staff. And so this was actually our protocol. We did our clinical right heart catheterization. We did an RV biopsy for research purposes. I already showed you that data. We then performed pressure volume analysis at rest during right atrial pacing and then symptom-limited supine exercise. So I'm going to first show you what happened when we pace the right atria. So as you know, there's something called the forced frequency response. So as we become more tachycardic, as our heart rate goes up, the ventricle will contract more forcefully because of increases in intracellular calcium concentration. You can see that in both idiopathics, which is the open circles, and the black squares, which are patients with scleroderma, there was an increase in contractility in both groups, but this response was blunted in the patients with scleroderma, suggesting some impairment in calcium handling. We then exercise those individuals, and you probably are not surprised that patients with scleroderma, who can be quite frail, exercise for less time. They achieve less maximal wattages. Pretty small numbers here, but a nearly significant less peak VO2 and higher VEVC2 slope. When we looked at our measures of contractility, afterload, and coupling, what we found is the patients with idiopathic during submaximal early exercise could increase contractility, where the patients with scleroderma had no reserve. Contractility did not change at all. Afterload increased similar in both groups, and therefore coupling improved slightly in the patients with idiopathic pulmonary hypertension, but actually fell in the patients with systemic sclerosis. But that's not the most intriguing finding here. The most intriguing finding is what happened to the patients with scleroderma when they exercised, and that is their RV began to dilate. You can see here that the end systolic and end diastolic volume of the patients with scleroderma increased significantly. And even though stroke volume was no difference between the two groups, because the RV dilated, that RV ejection fraction actually fell significantly during exercise in the patients with scleroderma. So here's just an example of those three groups, and I'll focus your attention on the patient with scleroderma. You can see with each stage of exercise that RV pressure volume loop is actually shifting to the right. That RV is dilating, whereas the patients with idiopathic pulmonary hypertension and without pulmonary hypertension, we did not see that same phenomenon. So what is happening here? What is happening is that these patients, because they lack RV reserve, they rely on the Frank-Starling mechanism to maintain stroke volume, even at submaximal exercise. They dilate in order to maintain that stroke volume. Whereas idiopathic patients and normals, at least during submaximal exercise, still have contractile reserve where they can increase RV contractility. So let me show you what that means here with the pressure volume loop. So if a normal patient exercises, all of you, you actually do have an increase in RV afterload, but contractility increases easily to match. In idiopathic patients, at least during submaximal exercise in this study, could increase to match that afterload. But patients with scleroderma, their contractility is already maximized. That end-systolic pressure volume relationship is fixed, so the only way they can deal with increases in afterload is to dilate. So we wondered, could we leverage this observation then to come up with a surrogate for RVPA coupling? And indeed, we found a pretty good relationship between exercise RV ejection fraction and resting RVPA coupling. And when we looked at these different parameters to predict resting uncoupling, it was only exercise RV ejection fraction that was predicted. Resting RV ejection fraction was not predictive. Cardiac output, PVR, NT-proBNP, none of our usual clinical measures predicted RVPA uncoupling. This also predicted time to clinical worsening. Now, of course, there's less invasive ways to do this. We don't necessarily have to use conductance catheters. This is one of the projects we're working on now where we're doing exercise MRI. You can see this is a normal subject. We have an MRI-compatible bicycler ergometer here. We can exercise in the magnet, and of course, the normal response is to increase both RV and LV ejection fraction during exercise. But we know that in pulmonary hypertension, that's not always the case, and I'll just have you focus here on the patients with pulmonary hypertension in this study. You can see all of these individuals had a normal RV ejection fraction at rest, yet half had a significant decrease in RV ejection fraction during exercise. Again, suggesting that that RV is likely at risk, and perhaps we need to be more aggressive with therapies in these individuals. So in the last few minutes here, I want to shift gears a little bit and talk about how these principles relate to right ventricular failure after mechanical circulatory support or durable LVADs. So everybody knows that right heart failure is bad. It's bad in every condition, including LVADs, but it's particularly bad in LVADs, right? Upfront mortality is high, and this worsens over time. Yet our ability to predict who's going to develop right heart failure is really not very good. So these are some of our early risk scores, and you can see the C statistics are in the 0.5 to 0.6 range, so essentially you can flip a coin to determine if somebody's going to develop right heart failure. But can we leverage what we just discussed in reserve to perhaps give us a little bit more information about the state of the RV prior to LVAD? Now you might say, well, that's problematic, right? Because the most common way we assess reserve is by exercise or dobutamine. These patients really can't exercise, and a lot of them are already on dobutamine, so how can we do that? And I would suggest that perhaps we could define reserve a bit differently in this population. That is, we could look at the response of the RV to LV unloading, either with pharmacologic vasodilators like nitroprusside, or perhaps even temporary mechanical support to try to reproduce what's going to happen after that durable VAD placement. So as we think about this, I want to go over a couple of conservation rules with you. So first of all, for any given cardiac output, the heart rate of each ventricle is the same, and so therefore the stroke volume of the LV must equal the stroke volume of the RV, certainly in most cases. And so if we give nitroprusside to somebody with heart failure with reduced ejection fraction, right, we're going to significantly decrease their afterload, and their stroke volume is going to go up, right? We use this drug all the time in the ICU. It works really, really well. Actually doesn't lower blood pressure very much as long as you have a big dilated LV. On the other hand, if you have an impaired RV, if you have no RV reserve, and you reduce afterload in those individuals, the RV cannot keep up. It's not going to fill the LV, and then you will not see the same increase in stroke volume index. So if preload is not maintained because of lack of RV reserve, stroke volume augmentation is reduced. So we wanted to study this principle, and so to do so, we performed a retrospective study with University of Pennsylvania in Toronto. We identified 70 patients who underwent a right heart cath with vasodilator testing, that's nitroprusside, as part of their advanced heart failure evaluation. But ultimately, they received an LVAD. They did not get a transplant. Most of these patients had the so-called combined pre-post-capillary pulmonary hypertension. Average PVR was around 5 Wood units, which if you take care of these patients, that's about normal for most patients. We defined right heart failure by the 2020 MCS-ARC definition, which is essentially 14 days of inotropes or the need for RVAD. And then we had a validation cohort of 10 consecutive patients. First of all, RV failure was common, right? 39% of patients actually had some degree of right heart failure after a ventricular assist device, and 20% actually had an RVAD. Now, for those of you that are interested in studying the RV in the LVAD space, it's getting harder. And why is that? Well, we have a lot of really good right ventricular assist devices now, and so these devices are being put in by different thresholds. Some people will put them in prophylactically, some people will put them in before they leave the OR, so it makes it a little bit difficult to determine the natural course of what that RV would have done. In this study, about half of those RVADs were planned. When we compared those who developed right heart failure compared to those that did not, there was really no difference in our typical characteristics. Their demographics, their intermax profile, baseline hemodynamics, echo, lab values, and none of our risk scores, including the Euromax, which is probably the best validated RV risk score, was no difference between the group. But what we did find was different is the response to stroke volume index when we gave nitroprusside. So the peak stroke volume index that could be obtained when we gave nitroprusside was a good discriminator of those who developed right heart failure from those that did not. And that was true if we only looked at the patients with the current device, the HeartMate 3, as also if we excluded those patients who required LVAD, or RVAD, excuse me. And in this group, if we could achieve a stroke volume index greater than 22 milliliters per meter squared, the risk of RV failure was indeed quite low. So this is clearly not perfect, right? There are some false positives and false negatives, but this might be a useful tool to have a shared decision-making conversation with your patient to say, hey, we think you may be at risk of high risk of right heart failure. This is what that may mean. It also may then lead the groundwork for a study to more aggressively treat these individuals in the OR, perhaps with temporary MCS devices. Right when we published that, another group in Italy really showed the exact same thing. A single center study, but differences in peak stroke volume index between those who did and did not develop right heart failure. And they took it one step further. They looked at the PAPI, the pulmonary artery pulsatility index. That's the pulmonary pulse pressure divided by the right atrial pressure, probably the best hemodynamic measure we have of right ventricular function, and saw the patients who developed right heart failure really had no increase in their PAPI compared to those who did not develop right heart failure, had a significant increase. And finally, of course, some really great work out of the group here at Methodist, suggesting that we might be able to use temporary MCS devices in a very similar way. So when they looked at those who did not develop right heart failure, those who did not had significant decreases in, of course, their wedge pressure, as you would expect, but also a significant decline in their right atrial pressure and significant improvements in the pulmonary artery pulsatility index. If you look at those who developed right heart failure, really no decline in their right atrial pressure and no improvements in their pulmonary artery pulsatility index. Now, of course, it's a little bit more complicated than that, right? Because it's not just about assessing the right ventricle prior to the operating room. There's a lot of stuff that actually happens in the operating room, a lot of stuff that cardiologists never know about, right? But there's a lot of different factors at play. One of those is the loss of pericardial integrity that occurs when we implant these devices. Also, the actual anchoring of the LVAD at the LV apex. This reduces LV twist. And this results in a decrement in RV septal function, which is responsible for the lion's share of RV function. We can also get adherence of that free wall, which we become much more dependent on, to the chest wall in certain cases. And so are there ways to mitigate the hit that the RV takes during the operation itself, not to mention bleeding and everything that can occur with that? And so I would say one possibility is a less invasive approach to an implant. So traditionally we do a median sternotomy, but there are ways either through a lateral thoracotomy plus a right thoracotomy or a mini hemisternotomy to implant these devices a little bit less invasively. This was first studied in a registry study called the lateral study, and you can see those individuals compared to historical controls had a shorter length of stay, they had less reoperation for bleeding, which may be very important, and there was only one RVAD in that entire group. Now, admittedly, these RV dysfunction was an exclusion criteria for the study, so these RVs were pretty good going in. So we wanted to look at this in the real world and worked with the folks in Germany who do a lot of thoracotomy implantations. This is data from 5 different centers, and we found in our overall cohort as well as in a propensity matched cohort that this less invasive implant strategy was associated with less right heart failure. We still don't really know the mechanisms from it, right? Is it just the reduction in bleeding that occurs, or is it something intrinsic about preservation of RV contractility? And so that leads me to the last study I'll show you, which we just published in ASIO. We actually measured load-independent contractility before and after implant in patients who underwent LVAD implantation in both conventional median sternotomy as well as a less invasive strategy. You can see here in the sternotomy group, contractility, RV contractility, declined significantly after implantation, where it was preserved in the thoracotomy group. Overall rates of right heart failure were lower in the thoracotomy group like we'd seen in the larger study. And if we looked at follow-up at 3 and 6 months, the thoracotomy group was actually on much less diuretic. And so perhaps even a more sensitive way to think about late right heart failure in these individuals. So to summarize, RV Reserve has prognostic and diagnostic value in HFrEF, HFpEF, and pulmonary arterial hypertension. It may also predict resting RVPA coupling and may be useful to predict right heart failure after VAD. How best to assess it and how to use it clinically requires further study, and that's what we're working on now, trying to develop an RV stress test when you have a patient you think may have hidden right ventricular dysfunction or you're concerned about. So with that, I'd like to thank you very much for your attention, and would also encourage you to visit us in July for our Charleston HFpEF conference. Thanks so much. Arvin.
Ryan, thank you. And again, always mind-boggling how you can simplify some of these concepts. And I've learned a lot over the period of years, from you on hemodynamics. Two questions. One technical, which I'll ask later, but the physiology, as you're talking about the compliance, and the delta change in your, I guess, arterial diameter, right, the PAs, can be imagined as a part of your compliance. And how does that translate when you take the whole vasculature as a conceptual framework of capacitance? And I know we started talking more about capacitance in the venous structures,
Sure.
but is there a way to measure the capacitance of the pulmonary vasculature?
Yeah, so I think everyone heard because you have a microphone. When we image the pulmonary artery, we're looking at the large pulmonary artery. And so there's a lot of different studies that have looked at changes in pulmonary artery distensibility and changes from systole to diastole to try to estimate compliance there. The problem is that the proximal vessel doesn't contribute that much to compliance, right? Only about 20%. So I think that is a little bit limited. Now there's ways to estimate compliance, right? A simple way is stroke volume over pulmonary pulse pressure. That's kind of the simple way to do it. There's some assumptions there. It assumes that no blood leaves the circulation, which of course is not accurate. That probably overestimates compliance a little bit. There's more sophisticated ways to do it that are more complicated. But I find that the construct of stroke volume over pulse pressure is a reasonable estimation. The main determinant of how much that proximal vessel is going to contract is still the resistance in the distal circulation. So there may be something we can learn from that, but I still think it's limited because it doesn't contribute a whole lot.
My second technical question is for the PV loops. What are your thoughts on calibration, and I don't know what you're using, saline calibration versus relying on imaging for calibration? Yeah,
so the two most common way people calibrate volumes is either with same-day MRI, which is what we do. Of course, there could be some minor changes that occur between the MRI and the conductance catheter study, but we try to make sure the heart rate's very similar and that sort of thing. The other way is the old Jan Bonn approach, where you inject hypertonic saline to calculate the parallel conductance and then allows you to back calculate ventricular volume. I think both of them are very reasonable. There are some folks, Bill Cornwell in Colorado uses the parallel conductance technique because he's doing this in VAD patients, and of course they can't get MRIs. So I think there's ways, if you don't have patients that can get MRIs, to do it. But there was a group in Europe that actually compared the two approaches and found very similar results.
So Dr. Tedford, first of all, this is a great talk. And
Thank you.
You've done some great work in this field. I had one comment and one question. And the first comment is regarding LVAD patients. As we know that there's very minimal increase in peak VO2. Although NYHA class subjectively improves,
Yeah.
the peak VO2 improvement is not very much. Retrospectively, and unfortunately this is not published data because we never pursued it, when we looked at the cardiopulmonary exercise testing data for patients who were evaluated with advanced heart failure therapies, eventually underwent LVAD implantation, the patient who had so people who had really high VEV-CO2 slopes actually had a very minimal increase in peak VO2 at 3 months after LVAD implantation, whereas those who had relatively preserved VEV-CO2 slope, they had more increases in peak VO2 as measured objectively rather than just a subjective NYHA class, suggesting kind of what you're saying, that is the RV functional reserve that is determining the improvement in exercise capacity after LVAD implantation. So unless we get an adaptive LVAD, we have to have a good functioning RV functional reserve to improve exercise capacity. And I don't know if that's something we'd want to look at in the future. But we looked at 30 patients, and that's what we found.
Yeah, I think we found something very similar. Quayton, who's now at MGH, looked at their data from when she was at Maryland, and it was a little bit unique because they implanted all of their VADs via thoracotomy. And when we had exercised patients with VADs previously, we actually saw a lot of patients who had significant increases in their LV filling pressures, suggesting that the pump wasn't unloading very well. Maybe they lacked some LV reserve. But actually in her cohort, and maybe it's just due to better placement of the cannula, the LV filling pressures really didn't change very much. But they still lacked significant reserve, and their peak VO2 did not increase much. And what she showed, it was all due to the right ventricle, and perhaps some of that was actually afterload issues, that there was an increase in RV afterload during exercise. But I think that RV is so afterload sensitive that any perturbation there is going to limit you. But yeah, they certainly, with very few exceptions, they don't increase their peak VO2 significantly, yet they still live a long time.
Okay, the question I had for you is when you looked at your IPH patients and systemic sclerosis, I understand the imaging for RV systolic function, but I think they have like HFpEF, they have RV diastolic dysfunction. So did you look at RV EDP, RV contour, the tracing of the contour, and RV EDP to RVSP ratio to see if, compared to systemic sclerosis PAH and IPH, was there more diastolic dysfunction? And then perhaps they have contractile reserve. The other thing was when you exercise them, are they different in terms of their delta mean PA pressure to delta cardiac output relationship? Are they different in IPH versus systemic sclerosis induced PA?
Let me answer your last one secondly. I don't know if we actually looked at the relation. In general, the scleroderma patients have lower pulmonary pressures, but similar and lower PVR. So I think the relationship would probably be lower in those patients, but I'd have to go back and actually look at that. In terms of diastology, we looked pretty carefully at that. So, with our conductance catheters, we measured tau and some of those other measures. We've done some single beat in diastolic pressure volume relationships and really not seen any difference. And then we also did this and looked at the myocytes themselves, because certainly these patients have fibrosis, but that's really not the whole story here. So if you looked at the passive tension between these two groups, idiopathic and scleroderma, again, this is just a single myocyte, so there's no fibrosis there. There was actually no difference between the groups, even though there was more fibrosis in the total heart and in the biopsies themselves. So no real difference between those two groups, which was a little bit surprising to us. I do think that there's a lot of emerging data, though, that talks about the importance of RV diastolic dysfunction and pulmonary arterial hypertension. It's still very load dependent, but I do think that there's a lot we're learning about that, as well as atrial function in these patients. Cindy.
So first, a statement of thank you for highlighting nitroprusside, a drug near and dear to my heart.
Drug,
exactly, a near and dear drug that I think is unfortunately getting substantially, increasingly underutilized. And I think it's an amazing drug that gives us a lot of information, just as you highlighted. So thanks for plugging that. And I will quote you when I'm back in the ICU again for its utilization. But just I think a little more simple concept that I wanted to get your 2 cents on. You mentioned it a little bit when you were talking about with Arvin. But what is your data, what have you seen of just a simple comparison of the pulse pressure in pulmonary hypertension patients? Because obviously we have a lot of different ones, and I come back a little bit to the congenital heart disease patients, where a lot of their pulmonary hypertension is more flow related than resistance related, where their pulse pressures are very different. Mm-hmm. And so any just simple predictors that you've seen there?
Well, if you think about what determines pulse pressure, right, it's a combination of the stroke volume, which is what you're getting at, and then the compliance of the system. And so if you take individuals who have similar compliance or similar PVRs, then the pulse pressure is going to be predictive. There's been a couple studies on pulmonary arterial hypertension, again, looking at that estimate of compliance, stroke volume over pulse pressure, showing that's a better predictor of outcome than some of our other hemodynamic measures like pulmonary vascular resistance, for example. And if you think about that kind of the RC curve, what you really see is compliance takes a huge hit early on. It's very steep, and then it really kind of levels out. So once your PVR gets above 3 or 4, the compliance doesn't change for very much. But I think One of the things that we've been interested in, and we published in Lancet Respiratory Medicine recently, is that compliance may be a better indicator of early disease when that PVR is in the borderline range, because that relationship is very steep, right? So if you, right, there's errors in the cath lab when you measure cardiac output, but so you may not be able to discriminate a PVR of, say, 2.1 from 2.8, but that individual with, with low compliance is likely to have real disease. So it might kind of serve as a harbinger of truth a little bit and help discriminate early disease in particular.
Thank you very
Sir.
much for your contributions and for putting this together, because I think it's not only unforgotten, it's more complex than we can think of. Well, we made the field in imaging a little more difficult for you to try to identify what is a good parameter of RV function. Mm-hmm. And the question to you, I want your expertise and your opinion, because I have my own. I think we have fractional area change, we have volumetric changes, we have shortening, and we have TAPSE, which I think a lot of our pulmonary docs hang on too much to it. It is an insensitive way of looking at RV. It's too simplistic, and I think people need to know what the problems with it is. Your thoughts regarding free wall strain as opposed to total strain, which appears to be probably the best so far. All of them are load dependent. But the other interesting thing is from an output point of view as opposed to function point of view, although you have a paradoxical septum that at times may be pushed quite a bit towards the LV, paradoxically, if the septum pushes more towards the RV in systole, it may aid in output as opposed. So I wanted your opinion of what do you use mostly at this stage of the game from a functional point of view.
Thank you, Bill. First of all, I'm very pleased to hear you say that strain is load dependent, because I think that's very much underappreciated. Whenever we've looked at measures of strain, the strongest hemodynamic association is always afterload. And so it is not a measure of contractility, as you know well, but I think that's not well appreciated. When we and others, and particularly the folks in Gießen who have done a lot of different comparisons between these measures and different non-invasive surrogates, the two that have really come out, one is the TAPSE to PAPSE ratio. Now, I agree with what you're saying about TAPSE, right? I think, one, of course, TAPSE is also load dependent. And so if you think about you're taking one parameter is load dependent and you're adding in another estimate of afterload, so you're kind of double correcting for load. And the R value there is somewhere around 0.6, but it's better than some of the other ones, at least in the studies that they have done. So that is one. I think it's a little bit, it may not be a perfect surrogate for coupling, but we know it is prognostic, for certainly after valvular disease, after valvular disease correction, for example. So TAPSE to PAPSE ratio, I think, is decent. I do think strain is the best, and I agree with you. I think it's more global strain, and the same group has shown that as well. That's the kind of the best non-invasive surrogate for RVPA coupling if you're not doing that. Now, there's of course other ways to do this, right? So there's these single beat approaches, and that's what we actually did in our last study that I showed you, where you don't have to have a conductance catheter and you just fit the RV pressure tracing to a sine wave. And there's ways to automate that, and so that's something that we're working on a little bit better to see if that's a better tool that we might have to assess the RV.
Oh, hi, Gerald Laurie. Excellent talk. Thank you.
Thank you.
I did have a question on a slightly different group of patients. We see quite a few people referred late with severe mitral regurgitation and impaired right ventricular function, often quite severe, and yet some of them do very well and some don't, as you indicated, the lack of predictability. And then the other factor I don't think I heard discussed was what to do in terms of assessment of the right ventricle after the onset of significant tricuspid regurgitation, and whether any of this work's applicable to that group, or do you have any thoughts on how to deal with that group in terms of selection?
Sure. So your first question about mitral regurgitation, it's I think there's a lot of emerging data in that field about the role of the RV there, and I would love to see a little bit more data. There's a little bit, but looking at stressing the RV prior to surgery and seeing what reserve capacity that individual actually has perhaps if this is a lot of functional MR, normalizing LV preload and looking at the RV response, similar to what we're doing in LVAD patients. There's a paper I just reviewed that suggested that we know when the RV is impaired, your outcomes are going to be worse, but if you wait, the outcomes are even worse than that. So, I think it's trying to find that sweet spot about the timing of that. And we know it's going to be a higher risk surgery, but that doesn't necessarily mean we shouldn't do it. But I do think that there may be a role for RV reserve testing to help better guide us in those individuals. Yeah, the tricuspid one, there's actually maybe a more technical side of things. When these conductance catheters were first validated for the right ventricle, they actually had models where there was no tricuspid valve. And they were actually still successful in determining volume. So, but it is tricky. There's a little bit of thought that you can look at different elastances. And so you'll look at the elastance in the pulmonary artery versus the elastance in the right atrium to kind of determine, maybe better discriminate load, because you have this offloading that occurs in the tricuspid regurgitation. But it's really, really tricky, right? And so we've been involved in some studies with some kind of unique ways to treat the tricuspid regurgitation. For example, one that was a stent that went in the IVC that had a valve on it. And so we were trying to look at measures of RV reserve to see if those were predictive or not. But you still run into that same issue with the pop-off valve in the right atrium, so it does make it more complicated. But again, I would hope that we might learn a little bit more from a reserve assessment than a resting assessment. But I think that's the next field right there, is to understand who does and does not benefit from tricuspid regurgitation, or dealing with the TR in those patients.
Yeah. Dr. Tedford, Adil Essen here with the heart failure team. So in a prior lifetime, I did a lot of work with PEs, and in that field, actually CT is universally done and utilized very frequently. So as cardiologists, we like to look at parameters that we ourselves assess and read. But do you think there's still a role for CT in understanding RV function and dysfunction?
Sure, I absolutely do. And I worked with my partner at Sheldon Litwin and used actually CTs from patients admitted in the emergency room with acute PEs, and we did a little bit of that. So, one of the things that you can get from CT, in addition to stroke volume and insystolic volume, you can get stroke volume and insystolic volume. And that ratio is also a surrogate for RVPA coupling. It's actually mathematically related to ejection fraction, as you may know. In the kind of mild to moderate range of ejection fraction, it's probably a better discriminator because it's a much steeper relationship. And so that's one thing that we might learn from the CT that's helpful. But I do think there's some value there. I think the issue that we might be challenging, right, is these CTs are done in the emergency room, and it's getting a quick, sophisticated read for some of these, more sophisticated metrics that might hinder that a little bit. But yes, I think we can learn a lot from CT, assuming they're gated and all that. Ryan.
Hey, Ryan, thank you. Thank you for being here. It's always amazing listening to your talks. Just a quick question. I think, just for understanding, when you're thinking about when you RV to PA coupling and you're measuring all this RV parameters and function and functional capacity, all things that you're measuring at it, as we know, the preload and also the interventricular dependency of the LV and RV, that how important it is with RV function. How do you correct that, or account for it when you're looking at the RV to PA coupling, when you do all the other assessment of RV function?
Yeah. Theoretically, the contractility should be load dependent, meaning both afterload and preload dependent. But I think in reality, it's actually not, because of the reason that you mentioned, at least on a global RV sense, because you get that septal deformation and you may get some dysfunction associated with that. There was a study that was done in dogs with chronic AV fistulas that looked at coupling before and after these, and actually at rest, or the contractility did not change despite developing volume overload in the right ventricle. But what did change was the reserve capacity of the ventricle. So when they gave these dogs dobutamine, the contractility did not increase as much as if you were volume overloaded, which actually has really important clinical implications, right? So if you come back from the operating room and your RV is dilated, you're not going to respond to inotropes very well. There was also some work that we did with giving saline infusions, and it does seem to impact contractility a little bit. So it is, I do think that there is some contribution there, and one of the things that we have done previously is actually controlled for end-diastolic volume, and so we normalize for end-diastolic volume that may get around that a little bit.
Thank you very much.
Thanks. Thank you. Appreciate it.